Hello and welcome to the clinicalpath.com lecture on testing in lung disease. Patients with lung disease present with two standard symptoms. They either present with shortness of breath or they present with a cough. The clinical approach to these two then, of course, is to do your history and the physical, and the physical exam is going to quite quickly take you to the basic division of lung disease, which is it going to be obstructive with bronchi or wheezing, or is it going to be restrictive, in which you might hear a few rales or crepitations. But after that, you really have to go to further testing to find out what the specific disease is going to be. And your basic panel of testing is going to be pulmonary function testing, which is basically about airflow. It's going to be about arterial blood gases, and let's put oximetry in with that, because that's going to basically be about gas exchange. And the last is going to be imaging, which is going to start with your chest x-ray and go on to your CT scan. So after the initial presentation of the patient, you're going to pretty quickly go to understanding and mastering those three tests, because that's what is going to allow you to investigate your patient. So when we talk about pulmonary function testing, we're really talking about airflow. Basically, we're going to use airflow to do our basic distinction into obstructive versus restrictive. That's a fundamental division in lung pathology. And the second, it's really, really useful for following your progression of disease. Your first initial pulmonary function test is going to be spirometry, and the test, therefore, is called a spirogram. And spirograms are tests which basically compare volume versus time. So let's just take a look at how a standard one works. You have your patient at rest doing normal resting inward and outward breathing, which are our tidal volumes. Then the patient takes a maximum inspiration and blows it out as hard and as fast as they can. That's going to be our critical parameter, and then they go back to their normal tidal volumes. So that's our basic spirogram. And we take a look at it, we can see that the functional pieces that we're going to use absolutely critically in medicine are going to be, first of all, this maximum inspiration to maximum expiration, which is going to be our forced vital capacity. That's going to be the key parameter for restrictive diseases. But the second thing we're going to do is we're going to take a look at the time of the entire process, which is going to run typically around 4 to 5 seconds. And then we're going to see how much of that expiration occurred in the first 1 second. So that's going to be our forced expiratory volume over 1 second. And that's often compared, just to adjust for body size and other parameters, we often compare that to the forced vital capacity, and normally that should be greater than 80%. So those are the guts of what we're going to get out of our spirogram, and note what we're missing. What we're missing here is we don't have any residual volume. So that's a major limitation of the test. So how are we going to use it? Well, we're going to use our forced vital capacity because it is going to be decreased in restrictive diseases. And we're going to use our FEV1 over FVC because it's going to be less than 70 to 80%, depending on whose criteria you want to use in our obstructive diseases. So those are our two basic parameters that we're going to use. The other test that we can use is the flow-volume relationship. So we can see on our y-axis we have flow, and on our x-axis we have volume. And we can see that our normal expiration, as we talk about the volume of air, is going to be a rapid expiration followed by our declining parameter. So that's going to be classic expiration. And when we inspire, you can see that's a pretty symmetrical curve. And frankly, I've never found the inspiration loop to be terribly useful. When we take a look then at the normal curve, we can look for our obstructive and restrictive patterns because they're going to show us very, very clear differences. When we take a look at our obstructive pattern, they don't have quite the same degree of maximum But the big difference is that they show this tremendous resistance in the middle. This sagging through the mid-phase of the expiration is what is proportional to the airway resistance, which is the hallmark of an obstructive disease. When we talk about our restrictive diseases, here we're starting with a lung full of air, say at 6 liters, and here we're ending up at 0 liters, then we can see in a restrictive disease, we're starting at a much lower initial volume because this is decreased in our forced vital capacity, but we can see that there's actually really good expiration because while there's mildly increased elasticity, the fibrosis also holds the airway open, so we don't see a fundamental disproportionate decrease in airflow. So then that's going to be our classic decreased total lung capacity with normal flow of a restrictive disease. While we're here, there's one other pattern that you should be able to recognize, and that is a pattern in which we see there's a maximum cap to our flow. So anytime you see this classic table, that's a classic example of an extrapulmonary obstruction. So certainly you're going to see this of every patient that is intubated, but you can also see it, for example, if there's paralysis of the vocal cords, or if you have a foreign body obstructing a duct or a cancer obstructing it. So this capping and plateauing of the peak flows is a good example of extrapulmonary obstruction. So in summary then, our flow loop diagrams are useful in restrictive diseases because what they show is that while airflow is normally decreased at low air volumes, because there's at the flat part of the elasticity curve of the lung, it shows that they are still proportionately preserved in restrictive diseases. So without comparing the flow to volume, you would say, well, those flows are low. But remember, flow is low when the lung is mostly collapsed because there's less elasticity. So the preservation of this flow relative to the volume of lung is very useful in characterizing restrictive diseases where the decreased flow alone might suggest obstruction. The other place that we really use these studies is in following progression of disease. And so there's just some parameters that we can put in our heads that are really pretty useful. If we take a look at how the progression of obstructive diseases looks, so this is obstructive, and we take a look at our FEV1 over the time, and remember these are diseases of years, what we'll see is progression of disease is going to show a relative decrease of FEV1. So the beginning of disease is defined as an FEV1 of 80% normal. When we get to the 50% parameter here, that's when we're first going to start to see the first drop in our O2 level. But the big one's going to be when we get to the 25% of normal function, because that's where we're going to see a O2 of less than 60, which is the definition of failure, and we're going to see an increase of PCO2, which means that we've got ventilatory failure, and now we're going to be associated with pulmonary artery hypertension and cor pulmonale. So FEV1 is a really useful parameter for following the progression of obstructive diseases. When we take a look at what we're going to follow with our restrictive diseases, what we really want to follow now is forced vital capacity. Again, this is a disease of years, and now we can follow the progressive fibrosis, and the forced vital capacity. We'll track and trend that with a very simple office test. So we noted that one of the major problems of using the spirogram is that it didn't really show total lung capacity or residual volume. To do those, or the so-called tests of lung volumes, we really have to use specialized tests that really aren't seen in offices, but more in tertiary centers with second-order testing. So the ways that we're going to get total lung capacity, or indirectly residual volume, there are two techniques for doing this. One is going to be gas dilution. And in this, the patient is given carbon monoxide or helium of a known volume, and then you measure its dilution throughout the entire lung, and the dilution is proportional to total volume. The other is what's called plethysmography, and this requires a phone booth-like structure in which one can compare the Boyle's law effect of total volume and calculate lung volume from that. And these are going to be important in diseases like emphysema and chronic asthma, where we have air trapping. The basic test we're going to use on gas exchange is going to be the measure of diffusion. The gold standard test for this is the so-called diffusion of carbon monoxide. And this is diffusion capacity of carbon monoxide is a specialized test, and diffusion, of course, is dependent on two parameters, both the surface area of the lung, which is decreased in emphysema, and on the thickness of the alveolar capillary membrane, which goes up in pulmonary fibrosis. The test that you're going to see used in everyday medicine, however, is to compare from the arterial blood gases the pulmonary artery O2 level to the relative level of inspired oxygen. And this is going to be the test that you're going to use when you suspect acute respiratory distress syndrome. And it works like this. You take your blood gas pulmonary artery oxygen, which should be in the 95 to 99 millimeters of mercury range, and you compare that to the inspired air, which normal room air at sea level is going to be about 2:1. So you can see, just if you pencil that in, that's about the same as doing 100 over 0.2. And so the normal range for this certainly should be greater than 400. But remember, when we talk about acute respiratory distress syndrome, we have our alveolar walls here, and they form these thick hyaline membranes from the proteins of the exudate. And it's those thick hyaline membranes that are going to create that diffusion barrier. So when we talk about ARDS, the proof that hyaline membranes are present is that now this ratio of blood oxygen to inspired oxygen is less than 300. If it's over 300, you don't have significant exudate in the lung. If that ratio drops to less than 100, that correlates with really severe disease. So diffusion of carbon monoxide, that's a tertiary center advanced special equipment test, but the one that you're going to use in everyday medicine is to take your blood gases and do a quick calculation to see if you can show a diffusion barrier to the oxygen. Pulse oximetry is just part of everyday medicine, so it's important to have some idea how it works. Remember that you're going to start with two different light sources, and they're going to be pulsing the fingertip, particularly the bed of the nail. And the two pulse sources, we don't have to know a lot about this, but you should have some idea of what's going on, is you're going to take an infrared wavelength, which is particularly absorbed by oxygenated hemoglobin. And then you're going to take a red wavelength, which is not. And when you compare those two and do some pretty good math and algorithms, you can come up with the percent of the hemoglobin that is saturated. So that's what you're getting out of pulse oximetry. It actually uses the pulses in the nail to differentiate arterial from venous blood. So percent saturation is always saturation of the periphery of oxygen, and it's going to be a percent. And normally it should be over 95%, and we start talking about hypoxia when it gets below 90%. There are a number of limitations to pulse oximetry that you should always keep in your mind. The first is that it reads carbon monoxide poisoning, so that's carboxyhemoglobin, and methemoglobin as saturated blood. So when you get into these toxicities, pulse oximetry doesn't work because it'll tell you your patient's blood is saturated when in fact it's actually got abnormal products. Remember that this does not measure CO2. So this is not a measure of ventilation. The other problem is that it's really insensitive to mild hypoxia. And that makes sense because when we take a look at what the oxygen binding curve looks like, remember that it's got this sigmoidal shape. When you're talking out here in the mild degree of hypoxia, in the 90 to 95% saturation range, you can see there's very tiny differences on the curve to measure. So if you're looking for the mildest change of hypoxia, you're just going to have to go to blood gases. And the last thing is, remember, it does not measure oxygen capacity. So you could have a patient with profound anemia and have a true decrease in oxygen to the tissues with normal saturation. So this is not a good technique to judge patients with severe anemia. But in everyday medicine, your first order screening test is going to be your pulse oximeter. When you really want to go to the gold standard, however, you're going to go to arterial blood gases, in which you do a puncture of an artery to collect it. So when we talk about blood gases, you're going to have O2, CO2, and pH, and from that then you're going to have a calculated bicarb. So here's our famous oxygen binding curve, and when you take a look at your blood gases, this is what you should be keeping in mind. So what are the points that we really want to pay attention to? Well, the first thing we want to talk about just briefly, because it's important and kind of interesting, is remember this is going to be affected by atmospheric oxygen. When you are in Denver, which is at 5,000 feet, Mile High City, you're going to have about an 80% PO2. And when you follow that up, that's going to correlate with an oxygen level of somewhere around 90 to 95%. So altitude matters. The key point we want to talk about, though, is the definition of failure. Because remember, the definition of failure is a PO2 of less than 60. And when we take a look at what that correlates to in saturation, because that's what we're going to be seeing from our pulse oximeter, that's going to correlate with about 90 to 91%. So failure at a blood gas of 60 is going to correlate to your pulse oximeter of about 90%. And that's why they always say you're going to have critical hypoxia and treat your patient when your pulse oximeter is at 88 to 90%, because that correlates with the definition of failure. And the other point, just as a reference point, is remember tissues have a PO2 of about 40, and that correlates with a saturation of about 75%. So those are our key parameters to take a look at when we think about the arterial blood gas oxygen and binding curve. Just while we're here, let's pay attention to these dotted lines, because remember, these are going to be our right and left shift. We see right shifts anytime we see situations of respiratory distress, so it goes up when we get an increase in CO2, when we get a drop in pH, and when we get an increase in 2,3 BPG. Left is going to be the opposite of those parameters. Remember, the other thing we want to add in is in the fetus, because hemoglobin F has a left shift, so the baby can strip oxygen from the mother's blood across the placenta. Okay, when we talk about carbon dioxide now, remember that carbon dioxide actually gets converted in the red cell to bicarb. So when we're thinking about carbon dioxide, we're talking about the plasma with water and CO2, but when that diffuses into the red cell, remember that that's going to be converted by carbonic anhydrase into our hydrogen and bicarb, which diffuse out. So you never get changes in the CO2 without also giving you changes in the pH. As well, remember that carbon dioxide binds to hemoglobin. It doesn't bind to the heme, it actually binds to the globin, and that gives us our carb, amino, hemoglobin, And that's what we talk about when we talk about the effects of the Haldane effect, in which adding oxygen can displace CO2 and cause an elevation of CO2 in the blood. So we've talked about oxygen and carbon dioxide. Let's just stop and review respiratory failure. Respiratory failure is defined into two patterns of disease. The first is going to be a type 1 failure, which is defined as a PO2 of less than 60 millimeters of mercury. And that's a really good spot to pick, because remember our oxygen binding curve, when we talk about where that 60 is, that's going to be a saturation of about 90, and that's right where we see it fall off on the steep part of the curve for binding. Type 2 refers to a PO2 of less than 60 with a PCO2 of greater than 50. And of course, what this tells you is there is failure with associated hypoventilation. With failure, you have to be able to differentiate intrapulmonary versus extrapulmonary causes of failure. And the AADO2 formula is how we do that. So that's the difference between the alveolar and the arterial oxygen. So remember, the little a corresponds to the PaO2 we get from our blood gases. So the question then is, how do we calculate the alveolar O2? And that's calculated by the formula of the atmospheric pressure minus the pressure that one gets from water, and that's times the inspired oxygen, which is going to be 0.21, and that's added then to the effects of the CO2, which is calculated by the PaCO2 over the respiratory quotient, which is about 0.8. So when we actually fill the numbers for that, at sea level our atmospheric pressure is about 60, and our normal expected water vapor is about 47, with an inspired oxygen of 0.21. And oxygen CO2 is normally about 40, so 0.8 over 40 is about 50. That's a minus, not a plus. So when we do the math on that, then that boils down to 150 minus 50 equals about 100. And so if we have A minus A, that's going to give us 100 minus our normal PaO2, which is somewhere between 95 and 98. So we can see that that's going to be less than 10 in a normal person. So if a person is in failure and the AO2 gradient is normal, then that's going to be an extrapulmonary cause. So that can be everywhere from central nervous system suppression by opioids to problems in nerve conduction like ALS, neuromuscular junction, myasthenia gravis, or skeletal muscle like dystrophy. If it is greater than 20, just to give it some margin of specificity, then that is going to be a pulmonary cause of failure. So when we talk about the pulmonary causes of failure, we're talking about diseases of diffusion. Remember, that's surface area, which is emphysema, and thickness, which is fibrosis. It's going to be VQ shunting, which we see anytime we get consolidation or a pulmonary embolus or bronchial obstruction, or anytime that we have an absolute anatomical shunt, which can be heart or lung. So once we've diagnosed failure, the alveolar arterial oxygen gap differentiates intra from extrapulmonary. Acid base is also determined, so we always, as a matter of convenience, start with pH. So that's going to either give us an acidosis or an alkalosis. After that, it's easiest then just to look at the CO2, because if the CO2 is low, then that's going to be a metabolic acidosis. If the PCO2 is elevated, greater than 40 millimeters of mercury, that's going to be a respiratory acidosis. Just to finish up on the acidosis side, once we've established a metabolic acidosis, the differentiation comes by looking at our anion gap. Remember, anion gap is sodium minus chloride minus bicarb. If that gap is greater than 15, in other words, it's an anion gap metabolic acidosis, that's going to be a mandatory differential diagnosis for the medical student, which is going to be a lactic acidosis, it's going to be renal failure, it's going to be diabetic ketoacidosis, and it's going to be the poisons. So our classic poisons are going to be aspirin. That's the one you're going to see the most in real life, but it also includes things like ethylene glycol, antifreeze, or our methanol from bad stills. When we come over to the other causes, the most important one here is going to be of a non-anion gap metabolic acidosis. The most important is going to be diarrhea. Remember that the colonic mucosa absorbs water and bicarb. So when you have a pure diarrhea, that's going to leave you with loss of bicarb and a metabolic acidosis. There are others, but I don't think really that's something that a medical student needs at second year. Well, let's take a look at the alkalosis side. When we take a look at the alkalosis side, we go take a look at our PCO2, and if it is low, then we know that we have a respiratory alkalosis. And respiratory alkalosis can be due to hyperventilation, and that hyperventilation we typically talk about as psychological in origin. So that can be things like fear and panic disorder. The other place we're going to see hyperventilation is in pulmonary embolism, because again, we have ventilation without perfusion, and the ventilation's to compensate for the hypoxia. When we come and take a look at increase in CO2, then this is going to be a metabolic alkalosis. And I think the only one that you really need at this stage in your career is to go to vomiting. Remember that the stomach makes acid, so when you have a pure vomiting disease, you're going to lose the acid, and that's going to give you a metabolic alkalosis. When we talk about the non-vomiting, these are a very complex group that mostly involve the mineralocorticoids, and so we discuss that specifically when we get into aldosterone disease, but I don't think that's something we're going to pick up off our blood gases. The overall general function test of respiratory function, just so you've heard of it, the general function test is the 6-minute walking test. And what it says is you give the patient a timed walk and you see how far they can get. A normal person should be able to walk more than 1,500 feet. And so anytime you get your renal transplant patient or patients that you've got chronic disease you're giving therapy to, you're going to be looking at that 16-minute test as a measure of whether they have normal function. If a patient can't even walk 600 feet, then that's a measure of really severe disease. The last of the tests, which you've noticed have included pulmonary function tests, arterial blood gassing, we now move on to imaging. And your basic screening test in imaging is going to be your chest x-ray. And you can see I've given you a normal chest x-ray here. And the truth of the matter is, looking at the absolute x-ray works if you have a mental image in your mind. So when we talk about the x-ray, this is the mental image to the right, which is how you should be translating what you see. So when we talk about the regions, let's go through them and see what they are. The first region is this region up here, designated number 1. This is our superior mediastinum. And the superior mediastinum has the thymus, the esophagus, and the trachea. And the diseases we see in it are thymomas and lymph node pathology like lymphomas. So if that area is expanded, you're thinking of thymoma and lymphoma, and it can compress the esophagus and trachea, giving you dysphagia and dyspnea respectively. The next region we want to look at centrally is region number 2, which is our aortic arch. And obviously this is going to be important in aneurysms and dissections from diseases like connective tissue diseases, of Marfan's disease, Ehlers-Danlos, from hypertensive causes in older people, and then of course syphilis for medical students. Number 3 here corresponds to the hilum of the lung. And the hilum of the lung is most important because it's a source of lymph nodes. So all the diseases that give me lymphadenopathy can give me hilar expansion, and that includes things like carcinoma and tuberculosis and sarcoidosis. Number 4 here, that is the right border of the heart. And that's important in an isolated sense for diseases of pulmonary artery hypertension. So that's things like cor pulmonale and recurrent pulmonary emboli, as well as the much less common primary hereditary diseases. The next thing we do is we take a look for cardiomegaly, in which we compare the width of the heart to the entire diameter of the chest. So in other words, the cardiomegaly is CD over AB, and that should be less than 50%. If you don't, that's cardiomegaly. And then the last area we really want to pay attention to are our costophrenic angles, because the angles are where we're going to see our effusions. And pulmonary effusions are critically important in diagnostic medicine for differentiating transudates and exudates. So when are we going to compare the chest x-ray to the CT scan? And the way you should think about it this, the chest x-ray resolves masses at about the 1 to 2 centimeter level, whereas the CT scan is going to pick things up at about the 3 millimeter level. So the commonest pattern you're going to do is you're going to do a chest x-ray first. It's quick and easy and gives you lots of information, and then you're going to follow that up with your CT scan, because that's going to give you your maximum sensitivity and specificity. So what are the pathologies you're expected to know at this level for abnormalities? Well, the following chest x-ray abnormalities you should be able to identify starts with consolidation. Consolidation refers to any solid whiteout pathology of the lung. Anything that gives you an alveolar filling fluid. So that can be anything from edema, and so that can be a transudate or an exudate. It can be blood. It can be pus. Heck, it can even be tumor cells. There are some tumors that shed cells like that. And when we talk about what that looks like, remember, it's going to be a solid whiteout. You see how easy it is to draw a chest x-ray? So you should be practicing thinking of your diseases as chest x-rays by drawing them yourself. So a consolidation is going to give you a solid whiteout. So anytime you see a lung field with a solid whiteout, that's a consolidation, and you have to identify the fluid that's filling the alveolus. So this would be a really good example here of a lobar pneumonia. The other pattern then that you've got to compare and contrast that to is what is reticular nodular. Reticular, Latin for mesh or net, and then with little solid areas in it where you get little areas of fibrosis. And when you see this, this is going to be our interstitial diseases. So that would be our atypical pneumonias or pulmonary fibrosis. And so when we talk about what that's going to look like, see how easy it is to draw the chest x-ray? That's going to give you this mesh-like look, and there might be little areas of fibrosis giving you the nodules. So that's a disease that would make a really good atypical pneumonia. If that was a young person with a dry cough and low-grade fever and headache, that would be a really good example of that. Next thing you've got to be able to identify on chest x-rays is a mass, because masses are always rule out neoplasm. So anytime you see a mass, remember cancer is a tissue diagnosis, so you've got to find some way to get that tissue. So you're either going to do a biopsy or you're going to do a fine needle aspirate to get cells to establish the diagnosis. Next thing you've got to be able to identify is atelectasis. And atelectasis is collapse of the lung. So if we think about our cancers as masses, we're going to think about our atelectasis as little plate-like areas in which we see these fine lines from the collapse. Of course, the other thing we want to think about is what would it look like if we had a large effusion. And so if we had a large effusion, then that's going to be the last of our important diseases, because that's obviously linked to compression atelectasis. So when we talk about our effusions then, we're talking about here's our lung x-ray, and we're talking about filling up. This is a vertical, so we can see the gravity effects. There's our classic example of a fusion, and again, the next thing we want to do is we want to tap it to differentiate our transudates from our exudates, because that's a fundamental division in medicine. So that brings us to the end of our discussion of diagnostic testing in lung. Remember, the three great families of diseases we're talking about is we're starting with our pulmonary function testing, and the key thing we have to identify that is our spirogram, and our key parameters are going to be our FEV1, which is often compared to FVC, and that has to be less than 80% for an obstructive disease. And we want to compare that to forced vital capacity, because that's going to be decreased in our restrictive diseases. So that's a really important place to start, and spirograms are a fundamental part of investigating lung disease. The second thing we want to talk about is gas exchange, and you have to be able to compare then our oximetry, which is going to be saturation, versus our arterial blood gases. And remember, two of the parameters we have to do of blood gases is we have to talk about failure, and there's two types, O2 down and O2 down with increased CO2, and we want to be able to talk about differentiating our types of failure using our AADO2. Remember as well, you have to be able to do acid-base balance from our arterial blood gases. And then the last thing we want to do is we want to be able to talk about imaging, and our basic start will be chest x-ray, and you want to be able to differentiate a consolidation from our reticular nodular, identification of masses, the areas of thin lines that are formed by our atelectasis, and then finally how to recognize an approach and a fusion. So that's the end of this talk. Thanks for listening. See you next time.